Good morning, everybody. Today we will discuss a very important topic related to pharmacology, and in that we will learn about the drug digoxin. So to study this, we need to look at these things that a nurse should know about a medicine. Let's try to discuss it using the name nurse itself. N-U-R-S-E. N stands for its name. For any drug, we should know its name and a bit more about its category and what it does. So, regarding digoxin, we see that digoxin belongs to the cardiac glycoside category of drugs, and these are positive inotropic, negative chronotropic, and negative dromotropic drugs. Now, why this is so, we will discuss a bit later in detail. From U for uses, we will see when we give this digoxin drug. So, we mostly give it in conditions of heart failure and atrial fibrillation. Then we have to study what the nurse's responsibilities are when the patient is taking digoxin. From S, we will see the side effects of this drug, and from E, we will see what health education we will give the patient. First of all, let's talk about how this drug falls under the category of cardiac glycosides. After that, we see that we call these drugs, based on their action, we will call them positive, inotropic. They are inotropic. Positive means that it will increase. Ino refers to muscle fibers. Ino is related to the fiber, and especially muscle fiber, and tropic is related to the action or effect, so based on what their effect will be, we give it this name. So these are positive inotropic. Positive means it will increase. Inotropic, ino is related to the fiber, meaning fibers are found in the muscles, in the heart muscles. It will increase that, it will increase its contraction, and tropic means this effect, meaning what it does. The action that is happening, that is what we have called it. So these are positive inotropes. Whenever we give this medicine, the heart's ability to contract will increase. This means the heart will contract much more powerfully and will be able to pump blood very effectively. That is why we give these drugs in conditions of cardiac failure or heart failure, because in heart failure, the heart can't pump blood properly. So we give it because its action is positive inotropic. Positive inotropic means contractility. So this means it'll increase contractility, allowing it to push the blood more effectively. This digoxin is also a negative chronotropic. Negative means it will lower, slow down, or reduce it. Chrono is related to time, and tropic means effect. So time refers to how many times the heart beats in 1 minute, which we call the heart rate. This means we use time to measure the heart rate. So the name chrono is used here in relation to that. It means it reduces the heart rate. Negative indicates it's decreasing, reducing, or slowing it down. Chrono is related to time, and we use time when we measure the heart rate. And inotropic means action. This means it will also decrease the heart rate, or slow down the heart rate. By acting on the SA node. So by working on the SA node, it will slow down the heart rate. That's why we call it a negative chronotropic. And digoxin is also a negative dromotropic. Negative dromotropic. Negative means it will decrease, tropic means effect, and the word in the middle is dromo. Dromo means conduction. These are all Greek terms. We've translated their words into other names, like dromo, meaning conduction. This means it will also reduce conduction. It will reduce the conduction by the AV node. The AV node. So the heart has an SA node and an AV node. The SA node determines the heart rate. Meanwhile, the AV node handles conduction, meaning it transmits impulses from the SA node through the atria and then into the ventricles. So when we administer this drug, digoxin, it acts as a negative dromotropic. This means negative will decrease it, and dromo means conduction, so it will reduce conduction through the AV node. We benefit from this when we have a patient with atrial fibrillation. That's when this action is useful, because in atrial fibrillation, the SA node functions normally, but in addition to the SA node, firing starts from everywhere within the atria, meaning impulses begin to be generated. If impulses start being generated from parts other than the SA node, it means the heart rate will increase significantly compared to a normal heart rate. For example, the heart rate could be 200 or even 300. So if the heart rate is that high and all the contractions in the atria have increased, what happens in a condition like atrial fibrillation is, for instance, here are our 4 chambers. Right here is the SA node, and from the SA node, 60 to 70 or 60 to 100 beats per minute are being generated. Besides that, if more impulses start forming automatically from anywhere else within the atria, then automatic firing begins or impulses start being generated automatically. So the upper atria, instead of contracting like this, it doesn't do that. It starts to fibrillate like this, in this manner. So it might fibrillate like this about 200 to 300 times in a single minute. Now from here, all of these impulses reach the AV node located here. Now if the AV node sends every single impulse down to the ventricles, then fibrillation would start there too. But that doesn't happen. To reduce it, the AV node itself filters out some impulses, but it can't stop them all. That's why we need a drug that reduces these excessive upper impulses before sending them down to prevent ventricular tachycardia. So this is where we use digoxin, and its action at that time is negative dromotropic. This means it reduces the conduction through the AV node. So it doesn't let all the impulses coming from above pass through the AV node. It will only send a limited amount or a limited number of impulses down. So from this, we've seen that digoxin is a positive inotrope because it increases the heart's contractility, or rather, it strengthens the heart's ability to push blood out. That's why it's called a positive inotrope. It's also a negative chronotrope because it slows the heart rate by acting on the SA node, and it's a negative dromotrope because it reduces conduction through the AV node. After this, let's take a look at how this normally we'll see that within our heart there are cells called myocytes, and inside these myocytes, within their walls, there are certain channels. There's one channel here, another one here, and a third channel right here. And inside these muscle cells, we have fibers that we call actin fibers, and interspersed among them are myosin fibers. The more these fibers constrict, the more the heart will contract, or a heartbeat will be generated within the heart, which is known as systole. In a heart failure condition, what happens is that this contraction within these muscle fibers becomes weak. It gets weakened. This means the heart won't be able to pump properly, and systole won't occur effectively, which leads to the condition of heart failure. So we need to give some medicine that increases these contractions. Okay, so for that, we give digoxin. Now we need to see why we give the patient a potassium-rich diet and why we measure the potassium lab values. To understand all this, we need to look a bit more closely at these things so that we can remember them well. All of these are muscle cells, which we call myocytes. Inside this myocyte, there's a channel here, one gate here, and one gate right here. This gate only, and let's assume that this is here, extracellular fluid. This area here is the extracellular fluid, ECF, and the fluid inside it is the intracellular fluid, which we call ICF, meaning the fluid inside the cell. This is the fluid outside the cell. We know that sodium is higher in the extracellular fluid, and sodium is lower in the intracellular fluid. See, I've drawn more sodium here. I've drawn a smaller amount of sodium here. In the extracellular fluid, calcium is also higher, and in the intracellular fluid, calcium is lower. Normally, through this first gate, or the first channel, only calcium can come inside. So calcium will come in from here, from the second channel. Sodium will come in, so sodium comes through this. And from the third channel, potassium will come. So we have three channels. The first channel through which calcium comes in, the second through which sodium comes in, and the third through which potassium comes in. Now, through this second channel, calcium will also go back out. Calcium can also go back out through the second channel. So this calcium will exit through this channel. So that means calcium came in from here and it will go out. But this only happens when sodium comes in, then calcium goes out. Remember, if sodium doesn't come in, calcium won't go out. Similarly, we have this channel. Sodium will come in through this channel, but go out through this one, meaning sodium will go out. So this sodium will go out from here. But here too, this only happens when calcium comes in, then sodium goes out. Potassium. If potassium comes in through this channel, then sodium will go out. If potassium isn't coming in, then sodium won't go out from here. So far, we've seen that in these channels, in our myocytes, there are three gate-like structures that we've called different channels. Calcium will enter through one, sodium through the second, and potassium through the third. The one through which calcium enters, we've called it the calcium channel. So this channel is what we call the calcium channel. After that, this calcium exits through another channel. But it only exits when sodium enters, so both are required here. So we can say an exchange occurs. This means sodium in, calcium out. If sodium doesn't enter, calcium won't exit. This means an exchange happens here. So we will call this gate, or rather this channel formed here, this one right here, we'll refer to it as the sodium-calcium exchanger, which is a protein that helps move sodium and calcium ions across the cell membrane. Right? Because sodium and calcium are exchanged here. And in this third channel, look, sodium and potassium interact. So we'll call this channel the sodium-potassium pump. Okay? So this sodium-potassium pump is the most important. All of digoxin's actions depend on this. So the first is the calcium channel. The second is the sodium-calcium exchanger, and the third is the sodium-potassium pump. Now, we'll see how this sodium-potassium pump, among sodium, potassium, and calcium, calcium is the most vital. To cause contraction in muscle fibers, we need calcium. Since calcium is higher outside, it enters from the extracellular fluid. After entering, this calcium moves onto these muscle fibers, causing contraction. And if the muscle contracts, systole occurs. Systole, or we can say the heart itself, will undergo contraction. Now what? After contraction, since sodium is higher outside, it enters the cell. But as soon as it enters, this calcium exits. This means the calcium inside is now decreased. Then, as we saw, sodium stays briefly, then exits while potassium enters. In heart failure, these contractions weaken, so we must do something to increase the heart's contractions. To increase contractions, we must keep more calcium inside longer, or increase the amount of calcium here. So to keep calcium inside, we have to make sure it doesn't leave. To stop calcium from going out, we'll give a certain medication. That's when we use digoxin. Now, this digoxin we've given to the patient, this digoxin comes and binds to this channel, the sodium-potassium pump. Digoxin binds right here. I've marked it with a D. D for digoxin. D for digoxin. This means digoxin is now bound here. If digoxin binds to this sodium-potassium pump, it means sodium can no longer leave from here because digoxin is bound all over. Digoxin here, digoxin here, digoxin here, digoxin here, digoxin here. This means it has blocked the sodium-potassium pump. Since the sodium-potassium pump is blocked, sodium can't exit. But what happens is, sodium is higher in the extracellular fluid, so sodium will keep entering from here. More sodium will come in from here as sodium enters here, and then sodium will keep coming in. When sodium enters, calcium was leaving at that time, but eventually the amount of sodium inside the cell will become very high. When the sodium level inside the cell increases, sodium isn't leaving from here. The sodium amount has increased. It's gone up. This means it was already high outside, and now it's high inside too, so the gradient difference is gone. So now sodium won't enter from the outside. If sodium doesn't enter from outside, then calcium won't leave either. So what happens now? As sodium kept coming in here, it couldn't leave afterwards because digoxin is bound to the sodium-potassium pump. Since digoxin is bound, it means sodium isn't leaving. Now, as sodium comes in, it's all staying inside the cell. It stays inside, which means the sodium level inside the cell has gone up. Now, no more sodium will enter from here because as the level increased, no more can come in. If it doesn't enter, it means calcium won't leave because we learned that when sodium enters, calcium exits. Now, sodium isn't entering because the level is already high, so calcium won't leave. If calcium doesn't leave, but calcium is entering from this side and not exiting, then we'll have plenty of calcium available. And the more calcium there is, the more it will trigger contraction in these muscle fibers. This means it will cause a very forceful contraction here. So that's why we call this. Therefore, we can say that contraction will occur in these muscle fibers, and the contraction will increase. And what increased it? This calcium. And what controlled the calcium from here? Digoxin. So that's why we said that digoxin is positive inotropic. And now as the contraction gets stronger, like when there's more push, the cardiac output will increase accordingly. And an increased cardiac output is exactly what we need. In heart failure patients, we need to increase the cardiac output. Now after that, we need to look at one thing. Why do we give digibind to this patient? Or let's say if digoxin toxicity occurs, we give digibind to the patient so that the digibind can attach to the digoxin circulating in the blood. And after attaching, it inactivates this digoxin so that it doesn't come here and bind even more. So this is the reason why, whenever digoxin toxicity occurs, we give digibind. When we give digibind, it binds with the digoxin circulating in the blood and inactivates it. By inactivating it, no more digoxin will be able to bind here. So that's one thing we have. So that's why we can say that this is a positive inotrope. And the second thing is that here, potassium and calcium are competitors of each other. In other words, we can say if this is our sodium and potassium pump, then the more potassium is bound to it here, the fewer locations digoxin will find to bind. So that means there won't be toxicity. But if this patient has hypokalemia, like suppose we gave the patient furosemide. If furosemide is given, well, furosemide is a potassium-wasting diuretic. This means the patient will have a potassium deficiency, or if the patient's potassium intake is low, it'll be low in their blood, and if it's low in the blood, less will reach here. If potassium is low, then on this sodium-potassium pump, potassium will also be low, and if potassium is low, then digoxin will come and bind easily here, binding all around and increasing in amount. So because of this, its effect, the effect we wanted, will be even more than expected, more than what we needed. So we can say that digoxin toxicity will occur here. So this will be digoxin toxicity. Why did that happen? Because we had this pump that we called the sodium-potassium pump, which I've shown here. So on this sodium-potassium pump, we normally have potassium receptors, and potassium attaches to them. But if in the patient, and the more potassium that attaches, the less digoxin will attach. It'll find fewer locations, less space to attach to it. But if there's hypokalemia, then all of its receptors are free, and more digoxin will attach here than should have. If more attaches, then it'll cause this action to happen more, and because of that, digoxin toxicity will occur. And after digoxin toxicity, many signs and symptoms will appear. So whenever a patient is taking digoxin, we must always measure their potassium levels to prevent hypokalemia, because if hypokalemia occurs, it will lead to digoxin toxicity. Therefore, we always provide the patient with a potassium-rich diet, such as bananas, potatoes, spinach, and oranges, so that their potassium levels remain stable. So from here, we've seen how these are positive inotropes and how digoxin attaches to the sodium-potassium pumps here. Next, we will look at this digoxin regarding these 4 chambers of the heart we have: the upper atria and the lower ventricles. Here is the SA node, and this SA node generates 60 to 100 impulses per minute, which spread throughout the atria and cause them to contract. After that, we have the AV node, and this AV node sends those upper impulses into the ventricles and causes them to contract. At the SA node, which is also known as the sinoatrial node, there are certain specialized nerve fibers that arrive, and these particular fibers are what we refer to as the vagus nerve. There are indeed vagus nerve fibers present there, and these fibers are considered to be a part of what is called the parasympathetic nervous system. Now, when this parasympathetic part of the vagus nerve becomes activated, then as a result, within the overall parasympathetic activity that occurs throughout the entire body, meaning the parasympathetic effect will take place, which lowers the heart rate. What it will do is, now if a patient has a high heart rate, how will digoxin work? Digoxin will act on this vagus nerve. It will stimulate this vagus nerve. As soon as it stimulates the vagus nerve produces certain chemicals at the SA node, which we call acetylcholine. And this acetylcholine will then reduce the impulses being generated here within the SA node. Reducing the impulses means the heart rate will then automatically decrease. So this action that was occurring is why we said that digoxin is a negative ion, a negative chronotropic agent. Why? Because the SA node is connected to vagus nerve fibers, and when we give digoxin to a patient, it causes vagal stimulation and increases vagal tone, meaning it increases the activity of the vagus nerve. When the vagus nerve activity increases, acetylcholine will be secreted at the SA node in our heart, and acetylcholine will then reduce the impulse generation that the SA node was performing. By reducing it, the heart rate will decrease. So this means whenever we give digoxin to a patient, their heart rate will decrease. After that, and there are some other fibers of this same vagus nerve that also reach down to the AV node. These will also reach the AV node, so when we give digoxin to the patient, at that time, acetylcholine will be secreted here as well. When acetylcholine is secreted, the conduction from here will decrease, and as the conduction decreases, it means the contraction in the ventricle will decrease, and this will lower the heart rate. And this is exactly what we wanted, that when we have a contraction, it should be powerful, meaning its force should be greater so that the cardiac output increases. But when the contraction happens, at that time, these ventricles of ours should be well filled with blood, meaning they must be filled. And if the patient has tachycardia, then the heart is contracting well, but it couldn't fill up properly because the heart will beat too quickly. If there's tachycardia, the heart will beat very fast, it will beat quickly, which means the ventricles won't be able to fill. The ventricle won't fill. So the digoxin we gave won't work that effectively because, you see, we've managed to get a good push, very powerful or forceful, but the ventricles are sitting empty. If the ventricles are empty or only half filled, then the cardiac output won't be able to increase properly. So we need two actions. The first action is to increase the force of the heart's contraction so that there's a good contraction, allowing a larger amount of blood to be pumped out. The second action we need is that this ventricle, this left ventricle, should be well filled. It should remain full of blood so that whenever a contraction occurs, more blood can be ejected. So if there's tachycardia, it won't fill well. It won't have enough time to fill up. But that's why one effect of digoxin is that it will reduce the conduction here and also slow down the speed of impulse generation by the SA node here. Now, what will happen because of that? The heart rate will decrease. When the heart rate decreases, there will be a good duration here, so this ventricle will fill up properly. After it's well filled, it will then be contracted forcefully, okay? So because of this, we can say that our vagus nerve reduces the conduction of the AV node. It reduces the conduction of the AV node. That is, the impulse conduction. It reduces the conduction. And to reduce conduction, for conduction, the word used is dromo, and it reduces it, which means negative. So this becomes negative dromotropic, and we need this action so that the heart's chambers, the lower ventricles, can fill up properly so that more blood is available for cardiac output. Similarly, here at the SA node as well, what it does is it reduces the heart rate. It will reduce the heart rate. That's why we've called it negative. We measure the heart rate in terms of time. The Greek word for time is chromo. So this becomes chronotropic, and we need all these effects, because if we only increase the contraction, but there's no blood available here, we won't get the full effect of digoxin. So two actions are needed. First, the heart should contract well. Second, when it contracts, the left ventricle must be completely filled with blood. So for this, we'll have to decrease the heart rate. The AV and SA nodes will decrease the heart rate because the vagus nerve goes there. So we can say that digoxin works in two ways. First, it will increase the contraction in these fibers, which is why we call it positive inotropic, and it will also do a second thing. It will decrease the heart rate. It'll decrease the heart rate in two ways. First, the SA node's rate. It will decrease the rate of the impulses being generated within the SA node. That's why it's called a negative chronotrope. The heart rate will decrease so that the ventricle gets enough time to fill up properly. Second, it will also decrease conduction through the AV node. It's decreasing conduction. The word for conduction is dromo. Decreasing is negative, and the effect is called tropic. This means it's negative dromotropic. And both of these actions, meaning the SA node and AV node, the reason the heart rate is decreasing from here is due to the role of the vagus nerve. The vagus nerve, which is a part of the parasympathetic nervous system, and its fibers extend all the way to here. When the parasympathetic nervous system is activated, then what will happen there? Acetylcholine will be secreted. When acetylcholine is secreted, all of these actions will take place. So far we've seen why these drugs were given these three names. After that, we'll look at its uses. So we mostly use it for two purposes. One is in the condition of heart failure when blood is being pumped less. The second is in the condition of atrial fibrillation. These are the upper chambers. In both of these, excessive contractions start to occur. Contractions happen because impulses come from the SA node, but they also start generating from anywhere on the atrial walls. Because of that, fibrillation will start to occur in it. So to prevent these from traveling downward and causing excessive ventricular contractions, we administer digoxin. Digoxin is mostly used in two specific conditions. First is heart failure, and the second is atrial fibrillation. Next, we'll look at the nurse's responsibility. So the nurse's responsibility is, whenever a patient's taking digoxin, we must monitor the apical pulse, because by checking the apical pulse, we can determine if the patient has bradycardia. Because if there's significant bradycardia, it means we can say the patient is starting to develop toxicity from this drug. We'll look at toxicity like this. If a patient let's say this patient takes digoxin. As soon as they take it, it enters the blood. Let's assume these are the blood capillaries, right here. So, from here, it enters the blood capillaries. Once in the capillaries, there should be a fixed level of the drug, digoxin, which we call the therapeutic level of digoxin. This should be 0.5 to 2 nanograms per milliliter. We call this the therapeutic range of digoxin. If it's within this range, there won't be any major toxic effects, meaning no adverse effects will occur. But if this level exceeds 2 nanograms per milliliter, then what happens? For instance, as this blood reaches up to the brain, and inside the brain we have a part called the medulla oblongata. Within this medulla oblongata, there are CTZ centers. We call these CTZ centers, which stands for the chemoreceptor trigger zone. Now, when we talk about these CTZ centers, or the chemoreceptor trigger zone, what we mean is a specific area in the brain that is responsible for detecting certain substances in the blood. So these CTZ centers, the chemoreceptor trigger zone, will actually detect and sense high levels of digoxin in the blood. This means that their main function, or the only thing they really do, is perform detection. They do not have any other role except for sensing and identifying these high levels. So these CTZ centers in the medulla oblongata will detect it. After detection, there are other centers in the medulla oblongata called vomiting centers. They'll send signals to the vomiting center, and the vomiting center then it sends signals back to our abdomen, diaphragm, and stomach, which causes us to experience nausea and vomiting. So this was the CTZ. The CTZ will detect that, hey, the level here is higher than 0.5 to 2 nanograms per milligram. After that, there are other centers here within this medulla oblongata, other centers that we call the vomiting center. This is the vomiting center, and the vomiting center will then send signals to the stomach, the diaphragm, and the abdominal muscles. Through that, vomiting will occur, the patient ejects it, meaning vomiting will happen. So the very first symptom comes from right here. And this question has been asked many times in the NCLEX. What is the early sign when a patient has digoxin toxicity? Its early sign will be, first of all, nausea, vomiting, and anorexia. Anorexia occurs because, for instance, the brain has detected a toxic substance in the blood, so it signals not to ingest anymore. That's why anorexia happens. Nausea and vomiting occur because when this level is elevated, the blood reaches the brain and enters the medulla oblongata. Inside the medulla oblongata is a center we call the CTZ center, and this CTZ center will detect it. After detecting it, it sends a signal to the vomiting center, and the vomiting center induces vomiting. These symptoms, which we call GI symptoms, are early symptoms. They are early symptoms of digoxin toxicity. After that, this blood reaches other parts of the brain. As the blood arrives here, it causes an imbalance of sodium and potassium within the brain tissues. When it causes a sodium-potassium imbalance, it leads to an electrolyte imbalance, and as soon as an electrolyte imbalance occurs, neurological symptoms will start to appear, which we'll say the patient will experience headache and confusion. So these will be neurological. Symptoms. And now this same blood with high digoxin levels, meaning digoxin toxicity, will then reach the retina. And in the retina, we know that this is our eye. The part of the eye is the retina at the back from where vision signals reach the brain. So here in the retina, there are also some cells. If I describe these cells, let's assume this cell also has sodium-potassium pumps, and digoxin will come and bind here. Once digoxin binds these cells within the retina, the sodium-potassium balance will also be affected there, which means the visual impulses that were supposed to travel from here to the brain will be impaired or distorted, leading to blurred vision. The patient will experience blurred vision. In addition to blurred vision, they'll feel as if there's a halo around any object, like a circle has formed. And this usually appears yellow because the cells in the retina start perceiving light in the yellow wavelength more intensely. Because of that, if we see something here, like if I draw a ball, when the patient sees this ball, it will look to them as if there's something yellow all around it, like this, creating a yellow halo. So we called it a yellow halo can sometimes be seen around objects. This usually happens because of the blood that is flowing to the eye, which can affect how you see things. Specifically to the back part, called the retina, also has sodium-potassium pumps in its cells. Digoxin comes and binds to those sodium-potassium pumps. Once digoxin binds there, the sodium-potassium exchange that was occurring inside can no longer take place, leading to a sodium-potassium electrolyte imbalance. As a result of this process, visual signals simply won't be able to reach the brain properly or efficiently. When these signals don't reach the brain as they should, it causes blurred or fuzzy vision, and light in the yellow wavelength is perceived much more strongly than usual, making it seem as if there's a noticeable yellow halo or glow around objects. These symptoms are considered the most classic and well-known ones, meaning they are the most reliable and trustworthy indicators we can use to confidently say that this condition is present. The patient has digoxin toxicity. These are the ones: yellow halos around objects and blurred vision. So we call these the most classic, or simply the classic symptoms of digoxin toxicity. So far, we've seen two classic symptoms of digoxin toxicity, which are eye-related symptoms like blurred vision and yellow halos around objects. However, the early symptoms are related to the GI tract, meaning nausea, vomiting, and anorexia. After that, as this blood reaches the heart, we saw that if there's a high concentration of digoxin in the blood, it will bind more extensively to this pump here. It will bind more, and if more of it binds here, so this means more calcium will be stored inside, and because more is stored inside, as a result of this, contraction will happen strongly. It'll be forceful. But the more digoxin there is, the more it will stimulate the vagus nerve. And when it stimulates the vagus nerve, we saw that more acetylcholine, or ACH, will be produced here near the SA node and AV node. Because of that, the heart rate will keep decreasing. So while we do want the heart rate to be lower, it shouldn't be so low that the patient develops bradycardia. And then the patient might suffer a heart block, so it shouldn't reach that point. We need to check for it. So the late signs of digoxin toxicity are exactly this. The patient will develop bradycardia. Yes, after that, among these symptoms, we'll look at the heart. So the symptoms in the heart will be bradycardia. So these are the side effects of digoxin. That is, when digoxin toxicity occurs, first, symptoms related to the GIT system will appear, which include nausea, vomiting, and anorexia. These will be the early symptoms. After that, our other symptoms will appear, which we call neurological symptoms, and those will include headache and confusion. And after that, eye-related symptoms will start appearing in the patient, which occur due to changes happening within the retina, and these include blurred vision and a yellow halo around objects. And this is considered the most classical symptom of it. Besides this, cardiac symptoms appear last in the patient. That is, when digoxin toxicity has been present for a long time or is in the late stage, then this bradycardia will occur in the patient. Now, if bradycardia is occurring in the patient, it means from here we need to see what the nurse's responsibilities will be. The nurse's first responsibility is to ensure bradycardia doesn't reach a point where it harms the patient. It could cause harm, so we must monitor for bradycardia. If the patient is in the hospital or under a nurse's care, we must check the apical pulse. The apical pulse is checked from here. The apical pulse is at the mid-clavicular line, the left one. We have two mid-clavicular lines. This is the clavicle bone. The line passing through its center is called the mid-clavicular line, and this mid-clavicular line is the left one, and it goes to the fifth intercostal space where the apex of the heart is located. There, we must listen to the apical pulse using a stethoscope. So the nurse's most important responsibility becomes listening to the apical pulse for a full minute. That will tell us if the patient is experiencing bradycardia. And how do we find the location of the apical pulse? It's at the left mid-clavicular line and the fifth intercostal space, which is just below the nipple area. So we listen from there with a stethoscope. Besides this, what else will we need to do? One main responsibility is that we'll monitor the heart rate. If the heart rate is low, if the heart rate in an adult patient is found to be less than 60 beats per minute, we will make sure to inform the doctor about this situation, okay? Alternatively, we may decide to withhold the medication. Specifically, this means we will withhold the digoxin. Now, if the patient we are talking about happens to be a child, if the heart rate in a child is measured and found to be less than 70 beats per minute, we will also withhold the medication, just to be on the safe side. This is because giving it when the heart rate is already that low could make it drop even further, which is something we definitely want to avoid for the child's safety. We will withhold the medication Digoxin in this situation, specifically if the patient we are treating happens to be an infant and if their heart rate is found to be less than 90 beats per minute. Again, that is, if the heart rate is below 90 beats per minute, then we will not administer the Digoxin. This is an important precaution to ensure the safety of the infant. Always remember to carefully check the heart rate before giving Digoxin, especially in very young patients. So, measuring the apical pulse is one of our biggest responsibilities. Besides that, we will also check the potassium levels, because the lower the potassium, the more space digoxin gets to bind with the cardiac cells. The more it binds, the more its effect will exceed what it should have been. It will have an excessive effect, which we would call cardiac toxicity. Therefore, we need to measure the potassium level, and we must maintain the potassium level. We have to tell the patient that they need to take a potassium-rich diet. Now we will look at some questions related to this. So let's start with the first question. A nurse is preparing to administer digoxin to a client with heart failure. This means the patient has heart failure. Heart failure means the heart is unable to pump blood properly. Which assessment should the nurse perform first? This means, which assessment will the nurse do first? So this has become a priority-based question. Check the blood glucose level. Well, if a patient has heart failure and is being given digoxin, there's no need to check the blood glucose level. It has nothing to do with this. The next option is assess the apical pulse. Yes, we will check the apical pulse because that's what we discussed while studying the theory. Because the apical pulse will tell us if the patient has bradycardia. If it's an adult patient and the apical pulse is less than 60, we will withhold the drug and inform the doctor. If it's an infant and the heart rate is less than 90, we will withhold the digoxin. If the patient is a child and their heart rate is less than 70, we will withhold this digoxin drug. So this option will be correct because we have to check the apical pulse. So the correct answer is B, assess apical pulse. Option C, measure the respiratory rate. That is, measuring the respiratory rate because digoxin and heart failure have nothing to do with the respiratory rate here. So that means we'll mark this one wrong too. Check the capillary refill. Checking capillary refill isn't that important in this case either, so that means the correct answer will be assess the apical pulse. Let's move on to the next question. A patient receiving digoxin has an apical pulse of 52 beats per minute. What should the nurse do? This means the patient is taking digoxin and their apical pulse is 52 beats per minute, so what will the nurse do? This means the patient has developed bradycardia. It's less than 60, which means it's bradycardia. Option A, administer the medication. That, you keep administering the medication even though we shouldn't because we need to withhold it, so this option's wrong. Second, hold the medication and notify. Yes, this is exactly what we need to do. When a patient has bradycardia, if it's an adult and it's less than 60, we must withhold the medication. So that's what we're looking for here, making this the right answer. After that, C, give half dose. No, giving a half dose doesn't make any sense either. Then, recheck in 4 hours. We can keep checking later, but our first action will be to hold the medication and notify the provider. Next question. A client taking digoxin reports nausea, vomiting, and seeing yellow halos around lights. Which condition does the nurse suspect? This means the patient is being given digoxin and is experiencing nausea. The patient has started having nausea and vomiting, and besides that, they're seeing yellow halos around the objects they look at. That's what we saw. So what would the nurse suspect has happened to the patient? When we were looking at the theory a little while ago, we saw that whenever a patient has nausea and vomiting, it's an early sign of toxicity. So digoxin toxicity has started. And if there are yellow halos, it's a classic sign of digoxin toxicity, meaning the patient has digoxin toxicity. So now, what will the nurse suspect is the cause? Option A, hypoglycemia. Hypoglycemia won't cause yellow halos or nausea and vomiting, so this is incorrect. Second, digoxin toxicity. Yes, it's because of digoxin toxicity that yellow light or yellow circles, which we called yellow halos around objects, appear around things, along with nausea and vomiting. So this is the correct option. Then there's hyperkalemia. In hyperkalemia, these symptoms like yellow halos aren't seen, so this option is also incorrect. After that, dehydration. These symptoms won't occur in dehydration either, so this is also incorrect. Let's talk about the next question. A client taking digoxin also receives furosemide. So this means the patient is being given digoxin, and in addition to that, they're also receiving furosemide. Furosemide is a loop diuretic, and it flushes out potassium. This means the patient will develop hypokalemia. What complication should the nurse monitor for? Meaning, which complication should the nurse monitor for? Hypokalemia, which is a low potassium level. Yes, since it's furosemide, it'll flush out potassium, leading to hypokalemia. So that's why we need to monitor it. So option A would be correct here. Hypernatremia. This is also incorrect here. Hyperglycemia, it won't be that. And hypermagnesiemia, it won't be that either. Whenever we give furosemide to a patient taking digoxin, we must always keep checking their potassium levels because we suspect that the patient might develop hypokalemia. Let's talk about the next question. A nurse reviews laboratory results for a client receiving digoxin. Which value requires immediate attention, meaning the patient is on digoxin therapy? Now, which lab value would require immediate attention, meaning we need to take notice right away? So first, potassium 3 milliequivalents per liter. So potassium 3 milliequivalents per liter. This means the normal potassium level is 3.5 to 5.5 milliequivalents per liter. So we can say it's right here. So this means this level is low. So hypopotassium is low, which means it's hypokalemia, and hypokalemia should not occur with digoxin. So this is something we need to attend to immediately. So that means this will be the correct answer here as well. The second option is sodium 138 milliequivalents per liter. The normal value for sodium is between 135 and 145 milliequivalents per liter. So this means it's within the normal range. So we don't need to pay any special attention to this. We need to identify the one that requires attention. So this option is also wrong. After that, calcium, 9.12. Now, when we talk about calcium, the normal level for calcium is 8.5 milligrams per deciliter to 10 milligrams per deciliter. This means calcium is also within the normal range, so this is also incorrect. Chloride 101, we can also say that chloride has nothing to do with this anyway, so this is also incorrect. Let's look at the next question. Which serum digoxin level is within the therapeutic range? So serum, meaning we need to state the normal range for digoxin here. Option A, 0. And if we talk about the normal range, it's 0.5 to 2 nanograms per milliliter. So option A, 0.2 nanograms, means it's low, whereas we need to state the correct range. Therapeutic range. So this will be wrong. 0.7 nanograms. Look, this is coming within this range, right? This means this is the correct range. This means its therapeutic range is 3.5 nanograms. Look here, more than 2, which means it's gone above 2. This means 3.5 is too high, and being high means toxicity will occur. So this won't fall within the therapeutic range. 5 is already high anyway. This means this also won't be in the therapeutic range. Next question. Which mechanism explains the therapeutic action of digoxin? Meaning, which mechanism explains the therapeutic dose of digoxin? That is, blocking the beta receptor. Does digoxin block beta receptors? It doesn't, because we've studied the mechanism, so this will be wrong. Inhibiting the sodium-potassium ATPase. Yes, it blocks or inhibits the sodium-potassium ATPase pump. This is exactly what we studied at the beginning. When we looked at myocytes, there were 3 channels on them. One was the calcium channel, one was the calcium-sodium exchanger, and the third was the potassium and sodium ATPase, the channel that was there for sodium and sodium-potassium ATPase. So it will block that, which means this will be the correct answer. Next is stimulating calcium channel closure. It doesn't close the calcium channel because it was closing the sodium-potassium pump, so this will also be wrong. Next is inhibiting acetylcholine release. Well, it doesn't stop the release of acetylcholine. We saw that when digoxin is given, it stimulates the vagus nerve. When it stimulates the vagus nerve produces acetylcholine. Acetylcholine goes to the SA node and AV node and reduces the activity there, which slows down the speed of impulse generation by the SA node, and it reduced conduction through the AV node. So digoxin actually increases acetylcholine activity rather than decreasing it. So this will also be wrong here. Now let's talk about the last question. The nurse is teaching a patient who is prescribed digoxin for heart failure. There's a heart failure condition, and the patient is on digoxin. Which food should the nurse encourage the patient to include in the diet? This means for a heart failure patient on digoxin, what diet will we advise the patient to take? Meaning, which food will we tell them to take more of to include in their diet? White bread? We won't suggest white bread because it doesn't have potassium. We need to include a food in the diet that contains potassium, so white bread would be wrong here. Bananas are a rich source of potassium. This means this will be the correct answer. It won't be butter or white rice either. So these were some important questions related to digoxin and the theory of digoxin. We'll meet tomorrow in a new video with a new topic. Thank you.